Dear students, in my lecture series in Obs and Gynae, the next topic for my presentation was puberty, basics and beyond. So it would start with all we need to know about puberty, and then I would be dealing with common conditions, common gynecological conditions which are present in and around puberty and a knowledge of which we all must have. Puberty is defined as a period of transition from childhood to adulthood. It encompasses physiologic, somatic, constitutional changes which are associated with further development of both external and internal genitalia and secondary sex characteristics. If you look at the timelines, normal puberty is approximately 10 years onwards and it lasts for 3 to 4 years. The passage from one stage to another is approximately 1 year. In Europe, the normal range of onset is 8 years in girls, but however, there are tremendous ethnic variations. In girls, breast budding or thelarchy, as it is called as, is usually the first sign of puberty. It is followed by the development of pubic hair, which is known as pubarchy, and then axillary hair. The onset of puberty growth spurt occurs by breast budding, and it is associated with a peak height velocity at mid-puberty. Menarche usually occurs within 2 to 3 years of thelarchy, and the median age of menarche is around 13 years in British teenagers. Age-related standards for pubertal change are there. Secondary sexual characteristics appear in 95% of girls between the age of 8.5 to 13 years. The average age of menarche being 12.8 years, it is said to be precocious if it occurs before 8 years in girls and before 9 years in boys. Now let us see what all changes occur at the time of puberty. The endocrine onset of puberty occurs several years before physical changes are visible. There is a pulsatile GnRH released from the hypothalamus, which stimulates pulsatile LH, luteinizing hormone release from the pituitary. With the progress, amplitude of this nocturnal response of GnRH, gonadotropin releasing hormone, increases and then gradually it reaches the adult pattern. With these rises, there is a rise in estradiol levels, which are responsible for various changes which occur at the time of puberty. So here you can see there are various factors which affect the onset of puberty. Initially, follicular growth does not occur, but as the estradiol level increases tremendously, there's follicular growth, and gradually, with estrogen excess, there's onset of thelarchy and menarche. Puberty is a slow process taking several years. The physical changes are progressive and are described as Tanner stages. The first change to be noticed is the appearance of breast bud, then pubic hair 6 months later. Menstruation, which is a late feature of puberty, correlates with slowing down of the growth spurt. Initial menstrual cycles are anovulatory and they are irregular. And this is a point which we must all note, because gradually with increasing age, the cycles would tend to be regular. And during this phase of puberty, supportive care is all that is needed. So the onset of puberty starts with pulsatile GnRH secretion. It is associated with pulsatile growth hormone secretion as well. So gonadotropins are responsible for sex maturation, while pulsatile growth hormone secretion is responsible for somatic growth. The biological clock starts. There are internal as well as external effects which help in increasing the levels of releasing hormones from the hypothalamus, which act on the pituitary, and then subsequently on the end organs, that is the ovary. So this is how stimulation of the anterior pituitary, release of LH and FSH, which act on the ovary, which are responsible for estrogen and progesterone, and which these in turn are responsible for various changes which during this period of transition, initial is thelarchy, followed by adrenarchy, then puberty. Then there's a peak height velocity, followed by onset of menses, that is menarche. The culmination of pubertal development is physical maturity. So it is not only physical maturity, but also with ovulation, the capacity to procreate. Thelarchy. This is the most common primary heralding sign of pubertal development. The breast bud appears at an average age of 9 years, though it could be any time between 8 to 13 years. Asymmetry in breast development is common, and it is best left to observation till complete breast development occurs, which is usually by the age of 16 to 18 years. One variation is the development of puberty before thelarchy. So pubic hair growth may start initiating before breast develops. Unilateral onset of breast development is also a recognized entity, and it may take 6 months for the opposite breast bud to become palpable. So you need to wait for these changes which gradually develop. Adrenarche. At the time of birth, the androgen producing fetal zone of the adrenal cortex undergoes involution and remains quiet till approximately 6 years of age when adrenarche begins. Adrenarche is defined as pubertal transition of the adrenal gland. This is characterized by an increase in serum levels of dehydroepiandrosterone sulfate, which occurs as a response of ACTH stimulation. Axillary hair. On average, the presence of hair in the axilla occurs at the age of 13.1 years in American girls and 12.5 years in British girls. Sebaceous secretion may appear at a mean age of 13.2. Further development of epicrine glands of the axilla and vulva becomes a reflection of increased adrenal androgens, which occur subsequently. So this is the sequence in which axillary hair growth occurs. Peak height velocity and growth. Peak height velocity has been calculated by measurements of standing height taken every 3 months during puberty transition. It is the greatest increment over a period of 12 months, and the age at peak height velocity is the midpoint of that interval. Peak height velocity immediately precedes the onset of menarche with an age range of 10 to 15.25 years. Now, breast development. The Tanner stages of breast development can be divided into 5 stages. Pre-adolescent stage 1, in which there is elevation of papilla only. Stage 2 is the breast bud stage, elevation of breast and papilla as a small mound enlargement of the areolar diameter. In stage 3, further enlargement and elevation of breast and areola occur, but there is no separation in the contours, means it is at the same level. However, in stage 4, areola and papilla project above the level of breast, and in stage 5, which is the mature stage, projection of papilla only, owing to recession of the areola to the general contour of the breast. So these are the 5 stages of breast development. Similarly, pubic hair development, pre-adolescent stage, in which vellus over the pubis is not developed further than that over the abdominal wall. It means it is only up to the abdominal wall and does not go on to the pubic region. In stage 2, there's sparse hair growth, long, slightly pigmented, downy hair. In stage 3, hair is considerably darker, coarser, more curled, and spread sparsely over the junction of pubis. It is at this stage that pubic hair are first identified in a usual black and white photograph. In stage 4, hair now resembles adult type. The area covered by it still smaller than the adult, but there is no spread to the medial surface of thighs. In stage 5, it is the feminine pattern, and it gets spread over the medial surface of thigh and as well as over the linea alba. These are the two stages, comparison of stages of development of breast and pubic hair. Now, what is the menstrual cycle? It is the process in which females ripen or release one mature egg. The average menstrual cycle will repeat itself about every 28 days, but normal menstrual cycle can be 7 days on either side. So they can be from 21 to 35 days. Normal blood loss is 30 ml per cycle. Normal cycle is of 20 to 35 days, average 28 days. Menstruation begins on day 1 and continues until about day 4 or 5. Follicular phase extends from day 5 to day 13. Ovulation occurs on day 14 and the luteal phase from 15th to 28th day. So here you can see levels of FSH, LH, estrogen and progesterone, which are responsible for the proliferative and secretory phases of the endometrium and subsequent. This is the menstrual cycle, the relationship between gonadotrophins, follicular development, gonadal secretion, and endometrial changes. Now the hypothalamus in relation to menstrual cycle. The hypothalamus secretes gonadotrophin-releasing hormone in a pulsatile form. GnRH activity is first evident at puberty, which we had already seen. Follicular phase of GnRH pulses occur hourly. Luteal phase of GnRH pulses occur every 90 minutes. Loss of pulsatility, downregulation of pituitary receptors decreases the secretion of gonadotrophin. Release of gonadotrophin-releasing hormone is modulated by negative feedback by steroids and gonadotrophins, that is LH and FSH. Release of GnRH is modulated by external neural signals as well. So this is how from the hypothalamus, gonadotrophin-releasing hormone acts on the pituitary, releases LH and FSH. These in turn act on the ovary and cause secretion of estrogen and progesterone. Initial phase, follicular phase, there's development of follicle, more of estrogen. Then gradually with ovulation, secretory phase, more of progesterone. And both these estrogen and progesterone have a negative feedback on the hypothalamus, which controls the release of gonadotrophin releasing hormone. Now the changes in the uterus. As you can clearly see, pre-ovulatory phase, the endometrium grows. Post-ovulatory phase, it further thickens, and then gradually menstruation occurs. And if you see the changes in uterus at birth, the changes in size, the ratio between the body of the uterus and the cervix at birth, the ratio is 0.5 to 1. That is, the cervix is bigger. At puberty, this ratio is 1:1. The body of the uterus and the cervix are of same dimensions, while in adult life, cervix decreases in size and the ratio becomes 1:0.5. So that was about puberty, the basics. Now coming to the common gynecological problems which may be seen prior to puberty or during and after puberty. One such condition is vulvovaginitis. This is persistent vulval irritation and vaginal discharge, which is most common reason for a gynecological referral of a prepubertal girl. The peak age for presentation in such cases is between 3 to 7 years. So a long way before puberty. Symptoms may present for several months or years and may be intermittent. She may have discharge, a yellowish green offensive discharge, which may cause vaginal soreness and vulval itching. Vaginal bleeding is not a typical feature, but still can occur. And if bleeding is present, a careful evaluation is always essential because it could be something else. It could be a foreign body which has been lodged there inside for a prolonged period. On inspection in such cases of vulvovaginitis, There's a typical appearance of a red flush around the vulva and anus, as you can see in this picture. The skin may be excoriated and there may be a pool of discharge, especially in the posterior portion. Low vaginal swab needs to be taken. In some cases in which they do not respond to initial treatment and a foreign body is suspected, in those cases, examination under anesthesia is always indicated. This combination of symptoms in a pubertal girl is known as non-specific vulvovaginitis, and it is mainly due to these various causes: poor perineal hygiene. During this phase, the level of estrogen is less, the lack of estrogen, the typical anatomy of the prepubertal vulva. Chemical irritation due to bubble baths and detergents are also one of the causative reasons. Vaginal swabs may be negative, but if they are positive, they usually show coliforms and group-A streptococcus. Candida is rarely found in otherwise healthy children. So now treatment for vulvovaginitis is usually conservative, and it mainly includes lifestyle changes like improved hygiene, wipe from front to back. If you wipe from below upwards, then perineal area which is having a lot of bacteria that can swipe onto the vulva and that may cause infection. Always avoid soaps and bubble baths in the area of vulva. Urinating with knees apart. Barrier creams, nappy creams can be used. They are advised to wear cotton underwear. Probiotics, which help in developing healthy bacteria in the vagina, or bio yogurts are advised. Broad spectrum antibiotics can be given if the swab is positive. They may help temporarily, but sometimes recurrence does occur and it is common. Symptoms usually resolve as the child approaches puberty because they are mainly due to low estrogen levels, hypoestrogenism. Now, next common condition which can be seen is the presence of a foreign body. This is not as common as widely assumed, but it has been seen in 4% of girls with genital symptoms without vaginal bleeding. Vaginal bleeding or persistent foul-smelling discharge, refractory to broad-spectrum antibiotics or the usual treatment should always raise the suspicion of a foreign body. The child may also admit insertion of this foreign body, and in this situation, examination under anesthesia is mandatory. Now, a third condition is precocious puberty. Precocious puberty is defined as appearance of secondary sexual characteristics before the age of 8 years in girls and 9 years in boys. It can be divided into two categories. One is gonadotrophin dependent precocious puberty, which means it is due to excess of gonadotrophins and is also known as central precocious puberty. The second category is gonadotrophin independent puberty, which is known as peripheral precocious puberty. There could be variants of premature sexual development in the form of isolated premature phalarchy, isolated premature putarchy, and isolated premature menarche. By this, we mean menstruation without other signs of puberty. So, if any of these developments occur alone, then they are isolated features or they are variants. Now, it can be further categorized into isosexual or heterosexual variety. Isosexual is where there are secondary sexual characteristics which are appropriate for the child's sex, while heterosexual or contrasexual are in which secondary sexual characteristics are in contrary to the phenotypic sex. That is, if the phenotypic sex is female and there is visualization, it is known as heterosexual precocious puberty. Central precocious puberty is always isosexual, whereas peripheral precocious puberty could be isosexual or heterosexual. Now, gonadotrophin dependent precocious puberty. This occurs when the HPO axis is activated. It may be idiopathic or there could be organic causes such as central nervous system tumors and malformations. Gonadotrophin in independent precocious puberty. In this, the presence of pubertal sex steroids are excessive when gonadotrophin levels are less, suppressed, or prepubertal. This may be due to disorders of gonads or adrenals, or some tumors which are secreting sex steroids. Now, there's a condition known as McCune-Albright syndrome. This causes precocious puberty because of isolated functional ovarian cyst. Ingestion of estrogens may also cause pubertal changes. Girls with precocious puberty should be investigated and always treated by a pediatric endocrinologist. There is no role for a gynecologist in the initial assessment, but on rare occasions, when examination under anesthesia is required to exclude local causes of bleeding, a gynecologist can be summoned. Now, the various investigations for this condition. Here, usually the bone is advanced, often by more than 2 years. Uterine volume is more than 2 ml per length and length more than 34 mm. A pear-shaped uterus and endometrial thickening in the form of endometrial echo would be seen on a pelvic scan, and these are supposed to be associated with progressive central precocious puberty. Baseline serum gonadotrophin levels may be raised. A GnRH stimulation test is the gold standard test for diagnosing this condition, in which we measure FSH and LH levels sequentially after administering GnRH analogs, a bolus dose of GnRH analogs. In healthy pubertal children, LH response is always more than FSH response. In prepubertal children and in Thelarche variant, FSH response would be more than LH response. In central precocious puberty, GnRH stimulation shows pubertal response with LH predominance. So the ratio of LH to FSH would be more than 1. Peak LH levels vary, but if they are more than 8 international units per liter, it is considered diagnostic of central precocious puberty. Estradiol levels are variable, not very reliable in this diagnosis. However, elevated prolactin levels are rarely seen in these girls with precocious puberty. Hyperprolactinemia is a common association with delayed puberty due to prolactinoma or non-functioning pituitary adenomas. In such cases, an MRI or CT would help to exclude central nervous system lesions. Treatment. The goal of treatment in precocious puberty is to halt or cause regression of secondary sexual characters, prevent early menarche, retard sexual skeletal maturation, and improve final height, avoid psychological and behavioral sequelae. GnRH analogs are the mainstay of treatment. Continuous stimulation of the pituitary gland results in a short period of pubertal stimulation. But after this, it is followed by downregulation of GnRH receptors, pituitary desensitization, and reduced gonadotrophin synthesis. And this is the basic for gonadotrophin releasing hormone analog treatment in such cases. Treatment with GnRH analogs is usually stopped when it is time for normal puberty to begin. So they are given till the normal age of puberty. The decision to discontinue treatment should be taken jointly by the endocrinologist of the child and the parents. Suppression of puberty seems to be reversible on cessation of treatment, and reproductive function seems to be unaffected. Pubertal manifestations generally reappear within months of stopping treatment, with a mean time to menarche of 16 months. So 16 months after you stop treatment, menarche usually begins. So that was about precocious puberty. Now another condition known as amenorrhea. Amenorrhea denotes absence of menstruation. It could be physiological or pathological. It could be primary or secondary. Physiological amenorrhea prevails prior to the onset of puberty, during puberty, during pregnancy, and lactation, and after menopause. So these are the four stages in which physiological amenorrhea is there. Pathological amenorrhea may be a result of many conditions. It could be because of genetic factors, systemic diseases, or some underlying endocrine factors. Now, type of amenorrhea could be divided into two: primary, which refers to the failure of onset of menstruation beyond the age of 16, and secondary, which refers to failure of occurrence of menstruation for a period of 6 months or longer in women who have previously menstruated or who have attained menarche. Amenorrhea could be a result of many causes. Outflow tract obstruction is a rare cause but a common cause of primary amenorrhea. Some congenital abnormalities can arise from embryological failure of canalization of Mullerian ducts. That is, there's a septum, a transverse septum, which is preventing the collected blood inside to come out, and therefore the girl is having primary amenorrhea. Or lack of development of Mullerian ducts, which is Rokitansky syndrome, the vagina and a part of the uterus is not developed. The correct regression of Mullerian structures in genetic male, but the development of phenotype due to androgen insensitivity syndrome. So in these three conditions could result in primary amenorrhea. Some other iatrogenic causes for amenorrhea could be Asherman syndrome, destructive oncotherapy, usually pelvic radiotherapy, and cervical stenosis. So these iatrogenic causes cause secondary amenorrhea. Now, this is a chart showing the various causes of primary and secondary amenorrhea. They can be divided into four. First compartment includes disorders of outflow tract, which could be Mullerian anomaly or androgen insensitivity in primary amenorrhea, or Asherman's and acquired obstructive conditions in secondary amenorrhea. Or second compartment includes disorders of the ovary, in which the ovary has not developed in primary amenorrhea, like gonadotropin, Turner syndrome, Sawyer's syndrome, or Savage syndrome, or it could be due to some end organ problems like in PCOD, the polycystic ovarian disease, ovarian masculinizing tumors, surgical removal, premature ovarian failure. The third compartment includes disorders of the anterior pituitary, some tumors like prolactinomas, and some genetic conditions. While again, it could be a hyperprolactinoma, Sheehan syndrome, empty sella syndrome in case of secondary. Compartment 4 includes disorders of the hypothalamus, Kalman syndrome, and adrenal hypoplasia in primary amenorrhea, whereas GnRH deficiency, excessive exercise, radiation, tumors, etc. in secondary. This is the list of investigations which could be used in identifying the cause of amenorrhea, because subsequently it can be treated only if the cause is identified. For primary amenorrhea, a whole abdomen and pelvic ultrasound, hormone levels, gonadotropin levels, serum FSH, karyotype of the patient's testosterone levels, prolactin, thyroid profile, estrogen levels, sometimes to rule out CNS lesions, a CT, brain, and in some cases, laparoscopy and hysteroscopy. While in cases of secondary amenorrhea, the first thing to be ruled out is pregnancy. Then FSH and LH levels and their ratios, prolactin level, thyroid, blood sugars, fasting and postprandial, whole abdomen and pelvic ultrasound, and laparoscopy and hysteroscopy. So these are the various investigations which prove useful. Now let us go through a case study. Laura is 14 years old. She presents with a 1-year history of pelvic pain. This was initially intermittent, but is now constant. It is severe. Even ibuprofen does not help, and she is currently off school because of her pain. Her periods have not yet started, so she has not attained menarche. On examination, you see something like this, a swelling in her pelvis and lower abdomen, and on inspecting the vulva, a bluish bulge is seen. Now, what do you think is the diagnosis? How do you know this is not a transverse septum? What is its treatment? And is there anything else to look out for over the following months? So yes, the treatment is imperforate hymen. The typical bluish discoloration of the hymen shows that blood is collected inside in the vagina, and it is because of imperforate hymen that the blood does not come out. This is not a transverse septum because the vagina is bulging, and the bluish appearance is due to retained blood. Septae are usually thick, higher up in the vagina. With a septum, the history may be identical, but external genitalia would look normal on inspection. So that typical bluish hue would not be seen. Treatment is incision and drainage under general anesthesia. A cruciate incision is given in the form of a cross over the hymen. The collected blood is allowed to drain off. Care, however, must be taken in order to prevent this hymen from resealing. So, stitches are applied so that this hymen remains open. In the subsequent following months, there could be an association between this Mullerian obstruction and endometriosis. Incision of the hymen should be curative, and routine laparoscopic follow-up is not indicated. But however, if this girl does have persistent severe dysmenorrhea over the following months or years, then endometriosis must be suspected and the diagnosis should be excluded. If it is present, it needs some treatment. So that was an overview about what Mullerian anomalies are. Millen has classified the mechanisms of anomaly production into 6 types: developmental arrest, cessation of development before completion, agenesis or aplasia, failure of normal development, hyperplasia, overgrowth, which means overgrowth, aberrant development, failure of normal resorption, and secondary degeneration of normally developed structures. Now, most frequent anomaly occurs from varying degrees of failure of fusion of Mullerian ducts. We know that there are 2 Mullerian ducts which fuse in midline to subsequently form the uterus, the cervix, a portion of the vagina. If at any level this fusion does not occur, then that may lead to these subsequent congenital anomalies. A is uterus duplex unicollis. There's one cervix but 2 horns of the uterus. B is uterus duplex with double vagina. So fusion is there up to the level of vagina. C is uterus diadelphus, completely separate 2 parts of the uterus, cervix, and vagina. E is septate uterus. Only a portion of septum has failed to resolve. F is uterus arcuate uterus. Only a stump has failed. And G is uterus unicollis with rudimentary contralateral hemiuterus. Only one horn has developed and the other part has not developed completely. So these are the various Mullerian anomalies. The American Fertility Society classification for congenital anomalies is the one which is universally accepted. Class 1 includes hypoplasia or uterine agenesis. Class 2 is unicornate uterus. Class 3 is uterus diadelphus. 4 bicornate uterus. 5 septate uterus. 6 arcuate uterus. 7 T-shaped uterus resulting from diethylstilbestrol use. Now, see this picture. This is a laparoscopic view of the uterus, which was seen in a girl who had menstruation and persistent lower abdominal pain during every menstrual cycle. So even though she had continuous menstruation in every cycle, still there was a bulge which was constantly increasing. So what do you think this is? So when a laparoscopy was done to identify the cause of her pain, we could see that there are two horns of the uterus. So this was obstruction with menstruation present. A double uterus may have one horn which is non-communicating and it becomes obstructed, causing worsening of pain each month. Menstruation from the unobstructed horn may be normal, and a delay in diagnosis in this situation is common. At final presentation, the girl will usually have a large and complex pelvic mass clinically and on ultrasound. Differential diagnosis in such a situation is challenging, and other causes of pelvic masses are often thought of. The anatomy may, however, be complex, and a pelvic MRI is usually required for planning treatment. Treatment, however, is surgical removal of the obstructed horn, and this can be done laparoscopically as well. So, Mullerian anomalies may be associated with renal anomalies also in up to 30% cases. An MRI can help us in identifying whether it is a renal anomaly, the site of kidneys and ureters, and would also help in preoperative planning. These are various syndromes associated with genetic disorders which are related to Mullerian anomalies. Mullerian duct aplasia, renal dysplasia, and cervical somite anomalies, MURCS syndrome, is a condition of unknown etiology. Then thalidomide teratogenicity also causes many changes. There's a condition known as urogenital dysplasia. Coming to a common condition, Rokitansky syndrome. This is also known as Mullerian agenesis, Mayer-Rokitansky-Kussner-Hauser syndrome, after the scientists who had identified it. It is also called as uterovaginal aplasia or agenesis, congenital absence of vagina and uterus, which is self-explanatory, Mullerian aplasia, and genital renal ear syndrome. These are all synonyms for Rokitansky syndrome. It is a condition in which there is complete Mullerian agenesis and is the second most commonest cause of amenorrhea. 10% after gonadal dysgenesis, which is 40%. It occurs approximately 1 in 5,000 pregnancies. The vagina is absent or hypoplastic. The uterus is absent, although there may be a small non-communicating rudimentary remnant, which is called as analgon, which may not contain endometrium. It may or may not contain endometrium. This is associated with concurrent abnormalities of the urogenital tract like unilateral renal agenesis, pelvic kidney, horseshoe kidney, hydronephrosis, ureteric duplication. In such women, the ovarian development and function is normal. So overtly, the phenotype is female. She is a female, but there is Mullerian agenesis. The vagina is absent, and in many times, the whole of the uterus is absent or is present in the form of a remnant. So this is how it looks on a laparoscopic view. Now, another condition which is common in pubertal girls is polycystic ovarian syndrome. In 1935, Steen and Leventhal described this syndrome, which consists of amenorrhea, infertility, and hirsutum. hirsutism. It was associated with bilateral and large cystic ovaries. It is the most common endocrine disorder among women in the age groups 18 to 44. It affects 2 to 20% of this age group, depending on how it is defined. Now, the three features for the definition are menstrual irregularities, hyperandrogenism, and presence of polycystic ovaries on ultrasound scan. When all these three features are present in young adolescent girls, then only it is labeled as polycystic ovarian syndrome. Otherwise, for women above the age of 20, two of these three features, two out of three, need to be present. It is one of the leading causes of poor fertility. Additional features could be obesity, oligomenorrhea, acne, virilization with clytomelagali, which is as a result of androgen excess, hyperandrogenemia. There's relative insulin resistance, so hyperinsulinemia, normal or elevated levels of estrogen, raised LH with alteration in the normal LH FSH ratio. Now, these are the various clinical presentations, ultrasonographical and investigational findings which are seen in a case of polycystic ovarian syndrome. And they can be easily depicted by this picture: hyperandrogenemia leading to acne, hirsutism, male pattern hair loss, elevated serum androgens. Ovaries on ultrasound appear polycystic, multiple follicles are there. It is associated with obesity, insulin resistance, menstrual dysfunction, oligomenorrhea, or amenorrhea. And treatment options include weight loss, oral contraceptives, use of anti-androgens. Another condition is Turner syndrome. It is 45X or 45XO condition in women. A female is partly or completely missing an X chromosome. It is not usually inherited from parents, means it's not genetic, no environmental risk factors, and the mother's age also does not play a role. It is a chromosomal abnormality in which all or a part of one X chromosome is missing or altered. Normally, we have 46 chromosomes. In Turner syndrome, there are 45. It is not that abnormality would be present in all cells. If it is present only in some cells, it is known as mosaicism. So it could be a Turner syndrome with 45 XO in all cells, or it could be Turner's mosaic 45 XO in some cells. In these cases, the symptoms usually are few and possibly none in others. Diagnosis is based on physical signs and genetic testing. The signs and symptoms include a short and webbed neck, rosette ears, low hairline at the back of the neck, short stature, swollen hands, feet, may be seen at birth. There are heart defects, coarctation of aorta is the commonest one. Diabetes and low thyroid hormone are seen more frequently. Most people with Turner syndrome have normal intelligence. However, they may have problems with spatial visualization, vision, and hearing problems may also be seen. So these are all the signs which we must look for if you are suspecting Turner syndrome. Short stature, low hairline, shield-shaped thorax, widely spaced nipples, shortened metacarpal core, small fingernails, navi or spots on the body. It is associated with primary amenorrhea. Rudimentary ovaries, gonads, streak gonads are present. Elbow deformity, poor breast development, coarctation of aorta, and webbing of the neck, and some typical facial features. Treatment. With hormone treatment, these girls can have menstrual cycles and can have normal breast development. However, they are unable to bear children without reproductive technology. Because of the streak gonads, they would need ovarian ovum donation, or surrogacy. There is no cure for Turner syndrome as such. Growth hormone injections during childhood may increase adult height. Estrogen replacement therapy can promote development of breasts and hips. Medical care is often required to manage other associated health problems. Now coming to congenital adrenal hyperplasia. This is a group of common inborn errors of metabolism which are transmitted as autosomal recessive traits. These enzymatic deficiencies are caused by an impaired cortisol production. These cause impaired cortisol production as a result of their intermediary role in steroidogenic pathway, which converts cholesterol to cortisol. There are three variants. Classic congenital adrenal hyperplasia is 21 hydroxylase deficiency present in 95%. 3 beta hydroxysteroid dehydrogenase deficiency, and the third one is 11 beta hydroxylase deficiency. When cortisol production is decreased, levels of ACTH rise. Overproduction and accumulation of cortisol precursors result as a result of proximal enzyme block. These precursors are then stunted towards the production of C19 androgens, androstenedione, and testosterone. And so, therefore, these people have clinical manifestations of realization and hirsutism. So, this condition could be evident in and around puberty. 21 hydroxylase and 11 beta hydroxylase enzymes are also used in mineralocorticoid pathway, which is responsible for aldosterone production. So, patients can have salt wasting form of the disease. So, this is how, due to deficiency of 21 hydroxylase enzyme, there's decreased cortisol and aldosterone, which leads to multiple health problems. But because there is increased androgen production, this leads to genital changes and early puberty. In the classical neonatal variety, there could be sexual ambiguity, progressive virilization, and sometimes salt loss or hypertension. These children require lifelong medical management and often surgical reconstruction of deformed genitals. The non-classic asymptomatic or the late onset variety is usually pubertal, and it is more common than the classic presentation. The reason why it is discussed here is that sometimes during puberty, this condition may be manifest. So this is all about puberty. Thank you for a patient listening. If you have any questions, feel free to contact me, and please subscribe to my channel. Thank you.